Good evening and welcome to ISRT Rayos 125 YouTube live session. We are so honored to have the guest speaker for today, Mrs. Sheeba Nair from SCTIMST Institute for Medical Sciences and Technology, Thiruvananthapuram. The topic today will be on MRI safety, and for the next 30 to 40 minutes, she will be delivering a speech on various safety aspects on MRI department. We have a question and answer session after this topic. So if you have any queries, please type your questions in the comment box and your questions will be answered after this session. Now, I would like to take this opportunity to welcome you, Sheeba, and to give a talk on MR safety. Over to you, Sheeba.
Thank you. 125 online program. Good evening all. Myself Sheeba. I am an MR technologist from SCTIMST Institute for Medical Science and Technology. Today I am MR safety. But you know that in MR there is no ionizing radiation. Right? You see MR actually healthcare professionals MR environment. Field MR system for clinical application. The number of patients that are coming for MRI Thank you, Mahesh. Welcome to Rayos 125 online academic program. Good evening all. Myself Sheeba. I am an MR technologist from SCTIMST Institute for Medical Science and Technology, Trivandrum. Today I will be discussing on MR safety. All of you know that in MR there is no ionizing radiation. But safety is little bit important in MRI because MR accidents have occurred worldwide. People, personnel, healthcare professionals, they have injured and killed in an MR environment. And also, the FDA has cleared a higher field MR system for clinical application. The number of patients that are coming for MRI with the implants, it is increasing. So there are certain potential hazards that are associated with the MRI. In order to deliver a safe healthcare through MRI, we should know that what are the potential hazards that are associated with the MRI, and we should follow certain safe practices to minimize these risks. So in MRI, we use a static magnetic field to produce magnetization in the patient body. And in order to produce an image, we need to switch on and off the gradients at a rapid rate. So because the cross-sectional imaging is possible by the application of these gradient coils. And the magnetization produced in the patient body is measured by using the radio frequency pulse. So for the excitation of magnetization, we require the radio frequency pulse. In MRI, we'll get most of the pathologies can be detected on a plain MR scan. But for the better characterization or the differential diagnosis, we may need to administer the gadolinium contrast agent. All these components have associated with a certain risk. So the main magnetic field, if we consider, we use most of the system use the superconductive magnet, which is on always, and the magnetic field strength is too high. We use 1.5 Tesla, 3 Tesla, or 7 Tesla systems. So if you brought any loose ferromagnetic objects into the near to it, it will attract to the magnetic bore with a huge force. We call it as the missile effect. So any ferromagnetic object, it will be attracted, and anyone falls in the path of this object will get severely injured or is injured. And also, if we bring any patient with the implants near to the magnetic field will cause rotation or translatory motion to the implant and can cause danger to the patient. Also, the superconducting magnets are use the liquid helium for cooling, and during a quenching situation, this will be released, and this release of free helium gas can produce risk to the patient. Concerning the gradient coils, during an MR imaging, we need to switch on it at a rapid on and off at a rapid rate. This can produce peripheral nerve stimulation, and also it can produce loud noise. So peripheral nerve stimulation and auditory safety are the main concerns with the gradient coils. The radio frequency pulse, we all know it's an electromagnetic radiation. So the magnetic field of the radio frequency pulse is used for exciting the magnetization produced in the patient body. But the electric field of the radiomagnetic pulse interacts with the patient body, and it will be converted into heat. So lot of heat can be produced during an MR excitation, and if it is exceeded, it can produce RF burns. Also, the rotating radio frequency pulses and rotating magnetic field, it can produce current in the conducting loops, and it can produce additional risk of burns. Gadolinium, the safety concerns are the nephrogenic systemic fibrosis and deposition of free GAD in brain. So these all we will see each separately. So the magnetic field, if we consider, it is not limited to the bore side. It will be extending outwards, and we call this as the fringe field. So as the distance from the magnetic field increases, the field strength, that is fringe field, decreases. So FDA consider the 5 Gauss line. It is the safe limit outside which the magnetic field will not affect the patients with the implants or other electronic devices. It doesn't mean that we can bring ferromagnetic material up to 5 Gauss line. And the fine Bose line extension, it depends upon the strength of the magnetic field. For an 1.5 Tesla, it will be 4 meter, and for a 3 Tesla, it will be 5 meter. And also the fringe field extension, it depends upon the magnetic field shielding. Shielding means we are producing additional magnetic field by using secondary coils and limiting the flux lines to the bore. So the magnetic shielding will reduce the fringe field extension, but the cost of the shielded MR system will be more. And the shielding will be different for different systems. So in a shielded system, till we approach the bore, the magnetic, the attractive forces will be less. But once we approach it, the magnetic field will start to pull the device at a huge force. So we cannot, this effect will be sudden and unpredictable, and the amount of acceleration occurring to a device, it depends upon the mass of the object, magnetic properties of the object. If that mass is too high, then the acceleration will be more. If it is a ferromagnetic material, then the acceleration will be more. So even we think that larger object will not be pulled into the magnetic. It's a false. Even these are the potential projectiles that have occurred in several places. So what to do next when such an incident occurred to you? So do not press the conch button immediately. See if there is no one pinned or there is no safety risk for the individual. Do not press the conch button. Do not try to remove the object. So this can produce additional hazards. So what you have to do is you have to inform the MR safety officer first. Then second, you have to call the MR engineer, and they will give you the instructions, and you have to follow that instructions. And FDA demands that any such adverse events occurred, it should be reported to FDA so that it can put guidelines and we can prevent such incident from occurring in future in other institutions. So the safety guidelines are, we have to restrict the entry to the MR controlled area where the MR scanner is located. All individuals, those who are working in an MR environment should be trained, MR safety trained, and all individuals entering to the MR, patient personnel should be screened for MR compatibility, and all equipment that are brought to the MR environment should be evaluated for compatibility, and all equipments that are near than MR scanner, it should be properly labeled. So this is a functional diagram for an MR unit. So the aim of this layout is that the MR scanner room should not be a free access to the public. The free access is provided to the zone 1, where the patient can enter into the radiology department and they can make their appointment, or they can give their request, they can consult the, it is the free access to the radiology department. Then there will be a second area called the zone 2, where their patient can change into the hospital supplied gown. Then there will be, here we can, very important thing, some patients will be coming on trolley or a wheelchair. So there should be a ferrous quarantine area where we can keep all these equipments. And after that, we can, the MR technologist can screen the patient at the zone 2, and then the screened patients can enter to the zone 4. And here, between the zone 2 and 3, there should be a safety secured patient access that either by biometric or key locking system should be there. And in zone 3, the screened personnel should be supervised by a level 1 MR trained personnel. And the zone 4 is the area where the MR scanner is located. Here, the patient has to enter along with the level 2 trained MR technologist. The labeling of the equipment should be done according to the FDA. There is FDA has approved only 3 labeling, that is MR safe, MR conditional, and MR unsafe. MR safe means mostly these materials will be non-metallic, non-conductive, and non-ferromagnetic, and they are non-hazardous in all MR imaging environment. The MR conditional means they are safe only under specified operating conditions. The specification will be in terms of magnetic field strength, magnetic field gradient, or the specific absorption rate. For example, if a device is say conditional at 1.5 Tesla, it will be safe at 1.5 Tesla. It will not be safe for 3 Tesla imaging. If those items labeled MR unsafe is contraindicated in all MR imaging environment, we should not bring such devices into the MR environment. These are the color coding: green for MR safe, this yellow triangle for MR conditional, and the red circle with a cross for the MR unsafe material. So it is also important that patient or the personnel, those who are entering to the environment should remove all their personal belongings. And also it is important that they have to change into the MR safe scrub that is provided by the MR facility, because most of the, even in clothes, there can be conducting material which will become dangerous to the patient while during the scanning. So coming to the RF safety, I told that this radio frequency pulse, once we give to the patient, it will increases the and there will be energy deposited in the patient body, and there will be an increased deposition of heat on the patient body. And the heat deposition depends upon the body mass, conductivity, heat capacity of the region of interest, how much is the blood perfusion of that area, and also it depends upon the room temperature, air circulation, and the type of pulse sequence and the RF frequency what we are giving. So there is the proper ventilation. It is very, very important in an MR room. And also we have to select the parameters in such a way that it should not exceed the recommended limits. The RF exposure, it is usually measured in a specific absorption rate, that is the amount of energy deposited in unit gram of tissue. And the SAR, it is like the radiation, it is regulated by the FDA. So here, for avoiding any radiation-related injury to the patient, the system will be provided with a different operating mode. So once we choose start scanning in a normal operating mode, the maximum energy deposited will be 2 watt per kg, so that the system will automatically terminate the examination if the body temperature rise to 0.5 degrees centigrade. But in certain pulse sequence, we have to enter into the first level mode. Only especially the steady state sequence will work in a first level mode. In such a condition, what we have, which will permit the total energy deposition to 4 watt per kg, and the system will terminate the examination when the body temperature is increased above 1 degree centigrade. And the second level mode is not for the clinical use. Actually, it is for the research purpose. And in this mode, the body temperature will rise to 2 degree from its initial temperature. So once these in the second level mode, there can be significant risk to the patient. So this needs the special approval from the ethics committee. And the SAR calculation, it is based on the body weight and the room temperature. So it is very, very important that while starting the scan, we should enter the patient body weight correctly, and also we should be we should be alert to the system pop-ups. So the SAR limit, when it exceeds, the system pop-ups will come. So when we are scanning the patient, certain patients, like pregnant patients, patients with the impaired heating relation, that is diabetics, or a patient having fever, or using the local transmit coils, in such situation, even if you are operating in a normal mode, there can be risk to the patient. So never use the first level mode in such patient, and even in normal mode, you have to monitor the patient carefully. And also, the proper ventilation should be maintained in a scanning room. So these are the sources of RF burns in an MR system. Any looped conductors or cables, the RF field, it is a rotating magnetic field which will induce current and can produce heat. So then cables touching the patient's skin. If the cloth it is having some conducting material, it can produce burns. The human body, it is a good conductor. If the human body forms a closed circuit, that is by crossing the patient hand, or crossing the toes, or touching the thighs, the patient body forms a closed circuit. It will be a large loop will be formed. In such situation, a large current will be produced, and there can be chance for RF burns. And also avoid the patient's arms touching the bore wall, and always keep the room temperature less than 70 degree Fahrenheit. So here you can see that these are the RF burns that have occurred inside an MRI. So the ECG leads, what we are using, it can also pose additional risk of heating if the leads are not insulated, or if the leads are broken, or if it forms a closed circuit, it can produce heat. So very careful while placing this ECG leads. So in order to reduce the risk of RF burns, always check that whether the cables are insulated. Avoid the formation of cable loop formation, and always use MR conditional ECG electrodes and other monitoring device. Use RF pads to separate the body part from the bore, and between the body parts you have to keep RF pads. And there should be temperature and humidity meters in MR scanner room. And also uh, avoid the touching the leads or any other monitoring device touching the patient's skin directly. And if you are not using any coils or cables, don't keep it in the region of interest. Instead, you remove that, and always give cues ball to the patient, and respond immediately once the patient press the cues ball. So coming to the gradients, I told in an MR imaging, you have to switch on the gradient at a faster rate. Even the fast imaging requires rapid switching of the gradients. So when these gradients are switched at a rapid rate, any conductive material there, it can induce electric current on that conducting material. And if these wires are in an anatomically or functionally sensitive area, which it can produce hazards. Also, the higher switching of the gradient, it produce electrical polarization, and it can cause the false release of neurotransmitter at the axonal terminal, and which result in peripheral nerve stimulation. So sometimes it can be very painful, peripheral nerve stimulation can occur. So the system will be provided with a different operating mode for the gradients. Once you choose the normal gradient mode, the system will not permit any gradient switching that will produce uncomfortable peripheral nerve stimulation. It will be prevented. But in certain pulse sequence, such as EPI sequence, you may need to enter into the second mode, that is the controlled gradient mode. Here, the gradient switching will produce peripheral nerve stimulation, but it will be not severe. It will produce mild peripheral nerve stimulation. The second level mode of uh, uh, gradient operation, there will not be any restriction, but it can produce the peripheral nerve stimulation. Also, if it can produce cardiac stimulation. So when you this second level mode, which is not used for clinical purpose, usually it will be used for the research purpose. Another big concern in MR is the noise. So when the gradients are switched at a rapid rate, there will be a movement of the gradient coils. There will be torque exerting on the gradient coil, and which will appear as the loud noise. So when the gradient switching is faster or the field strength is higher, the noise will be higher. So this noise can produce anxiety to the patient. It will make the verbal communication difficult, and also it can produce a temporary or permanent hearing loss. So these or the noise level also, it is regulated by the FDA. It has put limit that is 99 decibel is the upper limit for the noise that is considered safe for the patient. But all the MR system is capable of producing noise levels greater than the 99 decibel, especially the echoplanar imaging sequence. It produces the auditory noise level that is above the approved limit. So what is the recommendation is, all MR systems should use facility should provide earplugs or the headphones to the all patients, those who are undergoing MR examination. And also we should before examination we should verify that these ear protecting devices are properly placed and it is fit and it is functioning properly before starting the examination. So the FDA consider following are the significant risk examination. That is, if the field strength is greater than 8 Tesla, up to 7 Tesla, it is FDA approved for clinical use. And if the specific absorption rate exceeds 4 watt per kg for a period of 15 minutes, and the gradient switching, if it causes discomfort or painful peripheral nerve stimulation, that is also considered risky. If the auditory noise level, if it is greater than 140 decibel, it is also considered as a risky examination. So the gadolinium, I told, in a certain situation we may need to administer gadolinium contrast agent. The safety profile of gadolinium contrast agents is compared to adenated contrast agent is very good, and the gadolinium contrast agents are well tolerated by majority of patients, and the recommended dose is 0.1 to 0.2 millimole per kg dose we are injecting, and this dose is it is a safe for most of the patient. But patients with the acute or severe kidney insufficiency, that is if the GFR glomerular filtration rate is less than 30 ml, then what happens, the gadolinium will not be excreted easily from the patient body. It will remain in the patient body for a longer time, and there can be chance for releasing the free gadolinium, which is toxic and which will bind to anions such as phosphate, and it will result in tissue deposition. So this can leads to a systemic fibrotic disease, which is called nephrogenic systemic fibrosis, which will be mostly affecting the skin and the internal organs of the patient. And these nowadays for this free gadolinium release is more with the linear agents. Based on the gadolinium binding, we can classify the agents as linear agents and the macrocyclic agents. The macrocyclic agents, the gadolinium is well protected and their free release is not happening easily. So these linear agents, they are called the group 1 agents, that is gadodamide, gadopentate dihemoglobin, that is Magnavist, gadobercetamide. These agents have greater chance of NSF occurrence than compared to the macrocyclic agents, that is multi-hands, prohans, gadobutyral, dotara. These are the macrocyclic agents. Their NSF chance of getting NSF is very less. And here Yovist, which is in case of NSF, this is the most safe contrast agent. So also in a linear agents, there can be a free release of gadolinium, can cause deposition of gadolinium in brain, especially in the dentate nucleus and the globus pallidus of the patients who received a repeated gadolinium injection has shown gadolinium deposition. So this deposition of free gadolinium is another concern with the gadolinium based contrast agents, and the studies are ongoing on the effect of this free gadolinium deposition on patient. So once we have given a gadolinium contrast agents to a patient, when should we can give the next contrast agent? Thus, if sometimes it may require to do additional one perfusion or any other study, so then we may need to administer the second dose. So what should be the gap we should keep? Ideally, if the patient glomerular filtration rate is to the level of 60 ml per minute, good with a good renal function, after 10 hours of interval, we can give the second. And for a moderate respiration between 30 to 50, we have to wait for at least 48 hours for the another dose of gadolinium contrast agent. With the less than 30 ml, actually it is not recommended to give the gadolinium contrast agent. If it is deemed necessary, we can wait till 96 hours, then we can give the another dose. So coming to the implantable devices, so the implantable medical devices are classified into active implants and non-active implants. They are called passive implants. Active means they needs energy, either mechanical or electrical or magnetic energy for their function after implantation. Pacemakers, defibrillators, neurostimulators comes under this category. Non-implant, non-active implant means no need of power. Joint replacement, heart valves, aneurysm lips, and stents falls in this capability. And in active implants, their component, electronic components or the magnetic component make them incompatible. In passive implants, their metal components make them contraindicated, or they may throw artifact. So, if any patient is found out that they have an implant, so without checking the implant details, do not allow to enter the scan room. So, and what are the effects that can have the magnetic field on an implant? So, ferromagnetic implants or the device can cause injury to the patient, because these ferromagnetic devices will get magnetized in the magnetic field. So once they are magnetized, the magnet will try to pull this device to the isocenter, that is the attractive force. And also once in a magnetic field, this magnetized device will try to align with the external magnetic field, that is torque force can occur. And also these the RF energy will be deposited on this to the more concentrated to these implants, and which can produce heating. And certain implants, they can produce artifact which makes the image less suitable for diagnosis. The effect, it depends upon the magnetic field strength, the spatial gradient, and the mass, shape, and the magnetic susceptibility of the object. So the effect will be, if the higher the field strength, there is more danger, more more affected will be there. And if the spatial gradient is higher also, then the adverse effect on the implant will be very high. So once for scanning the patient with the implant, every department should have a policy. These policies should be designed for the identification, documentation, and imaging and aftercare. It should be covered, and also there should be any individual that is taking to the MR room should be properly screened for implant. And once we know that there is an implant, never assume the MR safety of the implant. We can just go to the mrsafety.com and we can type the implant details there. Then we can find out the make and model of the implant, and we can see that whether these devices are compatible. Also, we can refer to the manufacturer instructions for doing performing MR scanning with for patient with such implants. So the screening and the ferromagnetic detectors are the most important steps for identifying a risk in patient with the implants. So all MR non-MR personnel entering to the scanner room should be scanned, and non-emergent patient or non-emergent patient should be screened twice, and one of the screening should be done by a level 2 trained MR technologist, and emergent patient can be screened only once, but once, but this should be done by a level 2 trained MR technologist, and all conscious patients should fill the that say MR safety questionnaire. They have to do it themselves, and for unconscious and unresponsive patient, one of their family member or the guardian can fill the written MR safety questionnaire, and none of the columns should be left empty. And if in an unconscious patient there is no reliable patient history is not available, still the MR imaging is urgent, then we can take a plain radiograph, or we can review the old plain radiographs or CT or prior MRI. Also, we can thoroughly check the patient body for any scar. Then we can discuss about the risk benefit analysis can be performed, and then we can do the MR for the unconscious and responsive patient. And pediatric patients, those who are taken to the MR room should be screened twice, because they can carry at any time, they can carry MR unsafe materials along with them. So special attention should be given to the pediatric patient. So all facilities should have a dedicated screening form covering all aspects, safety aspect of implants. So once there is identified that there is an implant, the patient should undergo further investigation or the documentation for checking its MR compatibility before permitting into the zone 3. So the post MR implant scan, when we can do MRI for after an MR after an implant is placed in the patient body. So if it is non-ferromagnetic, we can scan the patient immediately. That is the materials which are made of titanium alloy, or titanium or tantalum. But if it is weak ferromagnetic material, which is recommended to wait for 6 to 8 weeks. So by that time, the fibrous tissue will grow over it, and there will be sufficient retentive and counter force developed within the implant, and so that will prevent the dislodging of the implant. So all implant patient always it is better to do the risk benefit analysis on an individual basis. What is the clinical urgency such a patient, and then we have to take the decision accordingly. Cardiac pacemakers, it is considered contraindicated in an MR environment because these pacemakers are their active devices. So the static magnetic field can cause movement, heating, or inhibition of the function of the pacemaker, or it can produce inappropriate or rapid pacing can be occurred due to the gradient or the R pulse. So it is a patient with a cardiac pacemaker, it is considered contraindicated. It was an absolute contraindication earlier. Now, on 2011 onwards, MR conditional pacemakers, and in 2015 onwards, MR conditional ICDs are available. Now we have the data about the MR of patients that who are undergone MRI with conditional and non-conditional MRI. Now this cardiac pacemaker, it's a relative contraindication. Then we can do MRI for patients with the pacemaker, but they have to follow the certain guidelines. Actually, the Heart Rhythm Society has provided guidelines for the doing MRI of patients with the pacemaker. It has provided the workflow for both the conditional and non-conditional pacemakers and ICDs. So, for performing a patient with the pacemaker, we have to check the most important thing we have to check is the pacemaker dependency of the patient. If the patient is too much dependent on the pacemaker, then it will be a contraindicated. But if the pacemaker dependency is less, and we can do the MRI, and also the non-MR conditional pacemaker, it is safe to do than the non-conditional devices. So all patients, those who are coming for MRI with the pacemaker, always there should be a risk-benefit analysis should be made between the cardiologist and the radiologist, and the patient should be well informed about the potential possible risk and the benefit she or he is going to get on MRI. And we have to get a higher risk consent form, and the EPA physician should change the program of the pacemaker. It should be done pre-procedure, and after the procedure also it has to be reprogrammed, and the patient should be monitored throughout the examination. If the patient's vitals such as BP, oxygen saturation, and ECG has to be monitored, and if the patient is it should be done by cardiologist or the EPI physician, it will be better. And always we use the, we should follow the safe condition. We should use the low SAR intense sequences, and always make visual and verbal contact with the patient. And if the patient reports any pain or any discomfort, you have to terminate the MR examination immediately, and we should take the patient immediately out, and we should have to manage the patient outside the MRI. So aneurysm clips, it is considered as a contraindication because these aneurysm clips are attached to the blood vessel. So even small movement, the bleeding can occur, and even death can occur. So the ferromagnetic non-conditional aneurysm clips are not safe to do take for MRI. But now in the clips that are manufactured after 95, they have tested for MR safety, and if the manufacturer is saying that it is safe to do under specific conditions, such clips we can imagine 1.5 Tesla, and these system may not be safe at 3T or 7 Tesla system. Stent and filters mostly MR conditional, and most of the stent and filters we can do the MR scanning. If not urgent, we can wait for 6 to 8 weeks. And cardiac valves, most of the cardiac valves, it is safe to do MRI. They are conditioned up to 3 Tesla, because even though this magnetic field will exert a small force on the it, compared to the heart force, it will be less. So it is safe to do the patient with the cardiac valves prosthesis in 1.5 Tesla or 7 Tesla. Most of the coronary stents that are available in the market, they are MR conditional. We can do the scanning at 1.5T or 3T. After, even immediately after the placement, we can do it. Most of the coils that are available, we can most of them are MR compatibility. So it is always better to check the compatibility of each coil separately. And we can, even some coils, the GDC coils, they are conditional up to 3 Tesla. So the shunt, there are two type of shunt: programmable and non-programmable shunt. These Chapra Metronic Codman are the some of the interventricular shunts that are used in our institute. And this Chapra, it is the non-programmable. Metronic and Codman are the programmable one. Both these all three shunts are conditional up to 3 Tesla. But the programmable one needs pre and post program post procedure MRI program check is required. If the program is changed, it has to be resetted prior to. So the neurosurgery consultation will be recurring for such patients after MRI. Deep brain stimulators will be placed inside the brain for the treatment of the Parkinson's disease, and this is placed in a very critical area in the brain. So we have to see the MR conditional safety conditions for this device. The device what we are using in our institute, it is safe at 1.5 Tesla, and we usually do this scan of these patients in 1.5 Tesla. And before taking this patient, we will switch off the battery and then we will scan, and after that this will be reprogrammed after completing the scans. So most of the autological implants, we have to check for the MR compatibility. So because these devices will have the electronically or magnetically active components, so it is always better to identify the make and model of each device, and those who are the so only those who are the conditional MR conditional devices only can take by following that safe conditions. These cochlear implants and all, they will have the magnet. With the implant, it is not safe to scan the patient. So we have to remove the magnet before doing the scans. So we have to see the each. We have to, if any patient comes with the ear implants, we have to identify that which implant is that, and when we have to check each evaluated each device separately, and then we have to take a decision accordingly. Most of the dental hardwares are there anchored well, and they don't have much safety concern. Only concern is they will produce a lot of artifact. But if they have any magnetically activated implants, they should be excluded from MR study. And most of the tattoos, mascara, talcum, or metals in the cloth, they can produce thermal injury or artifact. These tattoos, if they form a dark ink and forms a complete circle, the electric current can be produced and thermal injury can occur. So if it is the tattoo is too big, then for a safety we can place cold compress or ice packs before starting the scans. So drug delivery patches, if the patient comes with the drug delivery patches, there can be metallic foil which can cause thermal injury. Also, the RF can cause the drug change in drug delivery rate. So we should refer this patient to the physician for removal or repositioning. And if required, if we are continuing with the MRI, we should place ice pack directly over the patch to prevent the thermal burning. So the orbital foreign body, which is the most contraindicated, absolute contraindication in an MR environment. So any individual with the orbital foreign body should not be taken for MRI without further documentation. That is, if you found that any patient with the orbital foreign body, we have to review the patient radiograph, or if required, we can take CT and we can see that how much is the susceptibility artifact. And if required, we can ask the patient to remove the foreign body before proceeding with the MRI, because these in an MR magnetic field, these foreign bodies can move and can cause injury to the retina or the optic nerve. So we should be very conscious while doing the MRI of patients with the orbital foreign body. So also the contact lenses which can contain iron oxide, that has to be removed prior to MRI. So the bullets, pellets, sharpeners, these also has to be considered. For them, we don't know what is their ferromagnetic property, and also if these devices are located in a critical adjacent to a critical organ, their movement can cause additional hazards to the patient. So these things has to be taken care before doing MRI. And these are the absolute contraindication, considered absolutely contraindicated for MRI. That is implantable pediatric sternal device. That is magnet implant and a magnet tract. These have the magnets for the sternal correction, and this is absolutely contraindicated. Foreign body in the orbit. These trigger fish contact lens, gastro reflex device, insulin pumps, temporary transvenous pacing wires, abandoned intracardiac pacing leads. These are all the absolute contraindication for MRI. So, suppose if you have find out that there is a metallic thing inside the scanning, then you should know what should do in such situation. So this is an unexpected magnetic susceptibility artifact indicating that there is a foreign object in the patient body, but still now the patient is in the scan. So what you have to do is you have to immediately report it to the MR safety officer, and you have to assess the situation and where this artifact is located. You have to see the way that what is the where is it near a critical organ or something. So then you have to you have to take a decision whether we can proceed with the MRI or we have to take out the patient. So if we can review the patient all the films and whether they have done any prior MR imaging, whether this artifact is there previously. All this we can do quickly. And if the decision is to remove the patient from the MRI, then you have to be very careful, because when we are taking out the patient, you have to move the patient slowly out of the patient. Never ask the patient to sit up while they are out the scanning work. You just immobilize the patient, and then you shift the patient in a straight line parallel to the center of the magnet. Otherwise, the hazards will be more when you try to lift the patient, or when you quickly take the patient out. So concerning the pregnant patient, it is always a pregnant patient comes to the department. It's a clinical dilemma is there whether we can do the pregnant patient MRI or not. Actually, the available data, it shows that there is no harmful effects to the patients or the fetus of fetus of whose mother has undergone MRI in 1.5 Tesla MRI. There is no adverse effect it is reported, but we don't know the exact the risk that is associated with doing MRI during pregnancy. So we always do a risk benefit analysis for doing a pregnant patient MRI. If the potential benefit to the mother or the fetus is outweighs the expected unknown unclear risk, then we can do the MRI. And for that, the preferred field strength is 1.5 Tesla. But if that there is a clinical need for a 3 Tesla MRI to be done, then it can be done in the normal operating mode. In such situation, the total duration should not be more than 30 minutes, and the pregnant patients, those who are undergoing MRI, should give the consent form should be signed by themselves. Then also the gadolinium, whether it can give contrast to the gadolinium to the pregnant patient. That is another concern, because the gadolinium contrast agents, in animal studies shown that they can cross the placenta and remains in the amniotic fluid for a long period of time. There is no adverse effect have been reported to the fetus of mother, fetus whose mother have undertaken gadolinium-based contrast agents during their pregnancy. Still, its risks are not completely not. So intravenously gadolinium contrast agent should not be given to a pregnant patient routinely. But if the mother has a potential there is a clinical need of giving contrast agents to the mother, especially if there is a malignancy to be rolled out for a mother, then we can give the contrast agents to the pregnant patient. And also the pregnant MR imaging personnel, whether it is another concern, whether they can work in an MR environment. This is and a pregnant technologist, the ACR guidelines says that pregnant technologist can work in and around an MR environment throughout all stages of their pregnancy. They can work in 1 Tesla and 3 Tesla. Their safety 7 Tesla, it is not not. But only thing is that they should not enter the scan room when the scanner is scanning is going on. That is during the gradient switching. It is not recommended to enter the pregnant personnel to enter the scan room. So another concern is the breastfeeding, whether we can give gadolinium to a feeding mother. Actually, the amount, trace of gadolinium can come into the breast milk, but as far as the recommended dose for the fetus, it is very, very less. So the ACR guideline states that it is safe to continue breastfeeding after the maternal intravenous administration of gadolinium contrast agent, but we can inform the mother about the trace amount of gadolinium presence in breast milk. It is mother's choice. If she wishes, she can temporarily suspend the breastfeeding for 12 to 24 hours. So the pediatric patients, another concern for MRI, we have to follow all safety principle for the pediatric one in the same way the adults are screened. We have to screen in the same way. For child, those who are able to lie down without anesthesia, we can allow a single family member to accompany to the MR room. In such situation, we have to screen the accompanying person in the same way as the patient, and we have to give the ear protection and MR conditional seating for the accompanying person. And also if and for uncooperative patient, we can give sedation or general anesthesia by a group of trained personnel should do this sedation or general anesthesia. And also the neonates and the infants, they have the low GFR and the renal immaturity. So the gadolinium contrast agent should be given only if it is clinically necessity is high. And also the little one's ears are more sensitive. So all pediatric patients, we should give the ear protection device while before doing an MR procedure. So each institute should have the guidelines for the sedation, and it should be trained person. And also we have to keep a record of the patients, those who are undergoing this MR anesthesia. MR imaging under anesthesia, and we have to track the complications and more. Should have a quality assurance program to track the complications and the morbidity. So another concern is the prisoners and for detainees or paralyzed, they will have the ferromagnetic handcuff or bracelets or tracking devices. So these will be contraindicated in MRI. So this should be prior to their scheduling this MR examination for such patient. We should inform them prior that these devices are contraindicated in an MR environment. And also the accompanying correction officer, he may be carrying the weapon. We should inform them that none of the weapons should be allowed inside the zone 3 or zone 4. So another concern is the typical MR environments. We know that we have MR, intra-op MR, interventional MR, MR PET systems. So in such a system, the employing the MR safety, it is little bit concerned, because there will be multiple entry for the zone 4, and also the people will be there will be a lot of staff nurses, surgeons, then nuclear medicine people. So staff entering this into the patient will be different. So these modalities which will have the have separate standard operating procedures for the screening and performing in the safe examination. They should have separate policies should be developed, and the MR safety officer should monitor and should make sure that all the safety safety is followed at all time. So another concern now, we have the 7 Tesla MRA. So the 7 Tesla MRA, with the concerns are the higher field strength, then a greater RF energy. So the transitional, rotational and lenses forces on the implant, it is very high. So and also the resonant circuit formation. Actually, in 1.5 Tesla and 3T, the length at a higher length only the resonant circuit will be formed. But with the 7 Tesla, with a length of 5 to 7 centimeter, it will form resonant circuit, and heating can occur in a 7 Tesla. So this also there have been reported vertigo, tinnitus, hearing loss, nausea, motion disturbance, dizziness, magnetophosphines in a 7 Tesla MR environment. So the 7 Tesla MR environment, it requires special safety guidelines than the 3T or 1.5 Tesla. So now we are at the pandemic COVID. So during the COVID scenario, we have to follow certain guidelines. Actually, the MR imaging is not a routinely recommended for COVID patient. If it is non-urgent, we can postpone the examination. But if there is a clinical absolute necessity is there, we can do the MR scanning. And for each facility, it should have a written standard operating procedure for taking these COVID positive cases for MRA. that is always these patients should wear an MR safe mask or respirator. So mask they will carry this conducting metallic or conducting materials will be there. So that will be that has to be removed prior to MRI. And if a patient is having tracheostomy, we have to place a mask over the MR safe mask over the tracheostomy. And after the scanning, we have to thoroughly clean the patient contact surface by using an approved disinfectant wipe. Usually 70% alcohol or bleach solution can be used to clean the coils, tables, pads, accessories. Everything should be wiped with a disinfectant wipe. Never immerse the accessories or coils in a cleaning or a disinfectant liquid. If we can, if required after a positive patient scanning, we can down time or 30 to 60 minutes. It is recommended. So after an interval of 30 to 60 minutes, you can do the next scanning. So all facility should have a policies for managing emergencies in the zone 4, that is cardiac arrest or magnetic conch or fires. Fires. Actually, if when a cardiac arrest occur in a zone 4, first we have to stabilize the patient, and as possible as early, we have to evacuate from the patient from the zone 4, and we have to do the further management outside the zone 4. And we have to keep a MR safe fire extinguisher near the MR room, and all emergency responders of the institution should be aware of the hazards of the zone 4. Any emergency, if it is occurred, it should be informed to the MR safety officer first, and he should rush to the to the area where before the other people entering to the area. And one of the imaging personnel should remain at the entrance of the zone 4 during an emergency management procedure. And also, if any object or stuck or any emergency happened in an MRI, so when should we press the conch button? That is a question concern. So first of all, we should assess the severity. If the patient condition is life-threatening and we cannot wait till the MR engineer comes, then you can press the conch button. But otherwise, if the patient condition is not that much serious or we can wait, then you should not press the conch button. And also, if there is a severe fire, it has occurred in the MR scanner room, then that time also it is recommended to conch the MRI. So, coming to the conclusion, the most important step in an MR safety is the full stop or the final check that we made at the last, that is just before taking the patient. So we should see that all MR safety screening is performed, and we have to confirm the patient identification, and also we have to confirm that the patient status is not changed from zone 3 to zone 4, and we can instruct the patient that he will give a excuse board and for your assistance, and at any time he wish to communicate, he can press the board. And so now we realize that the MR safety, it is a very big concern, and most of the responsibility it is falls on the MR technologist. So what is the SCR recommendation for the number of technologists? There should be at least 2 technologists at a time in an MR facility, or 1 technologist and other person with the labeling of MR personnel. And these 2 technologists should be always at the earshot distance. And all MR personnel, that is prior to their employment, they have to undergo the screening process, and also any trauma or any ferromagnetic object introduced into their body later should be reported to the MR safety officer. So the safety training, it is very, very important as far as safety concerned. So all individuals, those who are working in an MR environment should have the safety trained in such a way that their presence should not cause dangers to themselves or others in the MR environment. So they are called the level 1 MR personnel. So the nursing staff, anesthetist, or any supporting cleaning staff, they should receive, give a first level MR safety training, and the MR technologists should be more extensively trained and educated in the all broader aspect of safety issues related to the MRI, and also the radiologist. They are should be more extensively trained, and they should they are named as the level 2 MR personnel.
Thank you, Sheeba. It was a worthwhile talk for both students as well as for technologists. So it's really worthwhile. I can say that you explained it very well, and you covered it extensively. So nicely explained it. So we have a few questions raised by the viewers. So let us go through the questions. Yeah, the question is, you said that gadolinium deposition is mostly related to dentate nucleus and globus pallidus. So, can we trace it by means of MRI, and how it can be traced is a question from one of the viewer. So, can you explain on that, Shiba?
Deposition is seen in the dentate nucleus
Shiba,
and the globus pallidus.
excuse me, Shiba, you are one more. Can you repeat the answer, please?
Now am I audible?
Yes, you are audible now.
Okay, actually, the patients, those who have received repeated gadolinium dose, on further MRI, we have seen that it is there is a hyperintensity on a T1 weighted image of that patient on the dentate nucleus and the globus pallidus. And actually, the exact reason why it is got deposited in this area, it is not clear. And also, the risk that is associated with this deposition also not it's not reported.
Okay, fine. So, one more question we have. What are the precautions to be taken by an MR radiographer or while doing a cardiac MRI with pacemaker? So, he's asking whether is it necessary for a cardiologist to be present while we are doing a cardiac MRI. So, what is your answer on that?
Actually, it's the cardiologist's presence is very much essential in an while performing an MRI for a patient with the cardiac implants, because anytime there is any emergency can be occurred. So there should be, we have to arrange all facility for emergency management in this patient. So the cardiologists are more better in dealing with these emergencies. And also for all patients, while we are doing the these pacemaker patients for MRI, always we should do the risk benefit analysis, and we have to inform the patient about the potential risks that are associated with the MRI, and we have to get the consent form, and we have to give them the cues board, and we have to verbally communicate with the patient throughout their studies. And also we can inform the patient that what are the possible risk that can occur, that is they can feel pain or their heart rate can be increased. So any change in their vitals, or they are feeling any uncomfort, they should immediately report to the technologist.
Yeah, fine. Then we have two more questions, I think. One is there any precaution to be taken by a pregnant MRI woman for any particular sequence, or should he or she should be away from the MRI work for the initial for the first trimester?
Actually, for a pregnant personnel, if it is concerned, it is no need to. It is the ACR what it is recommended that they can work in an environment throughout their all stages of pregnancy. They can enter into the MR scanner room for positioning the patient, injecting the contrast, and they can do the scanning. Only thing concern is that they should not remain in the MR scanner while the scanning is going on. And as far as the pregnant patient, if it is concerned, certain sequence there are auditory, theoretically there is an auditory safety concerns are there. Actually, it is no adverse effect till now. It is reported. Still, the echoplanar imaging it will produce more loud noise, and also the higher Tesla system will be having more noise. So such a sequence should be avoided in patients. Those who are undergoing MRI.
Okay.
So,
yeah, fine. So another question is, if a patient come to MR department with a shunt institute, so as an MRI technologist, what precautions should we take, or what we should advise to a patient who is having a shunt?
actually, we have done cases in mostly if 1.5 Tesla is available, we can preferably do scans in an 1.5 Tesla. And also we can instruct the patient about the possible sensations like any heat sensation or anything unusual. They can report to us immediately. And also most of the interventricular shunts, it is safe to scan up to their conditional up to 1.5 Tesla. That is if possible we can see they most of the patients they will be having a surgical knot. On that we can try to find out what is the make and model of that particular device, and then we can follow according the manufacturer's instruction. And also if it is identify that it is a programmable device, then after scanning we can tell the patient to consult to the neurosurgery team, because they have a device to they can check that the device is working properly, or otherwise they can reprogram the device. There can be a changing the program.
Okay. Then a question we normally receive from other institutes where we are doing MRIs and also is when should we move to first level mode during the scan? So you should that second level mode is for research studies and all. So some queries have been asked when we should move to a first level mode from a normal mode.
Yeah, actually, when we are doing this T1 weighted sequence, we may need to enter into the first level mode. Then steady state sequences and echoplanar imaging sequences, when we are doing, we may have to enter into the first level mode.
Fine. So one question from my side. So it's not a question asked by the viewers. So this question is something different from the safety view of MRI also. So can we give both MRI contrast and CT contrast on the same day? Suppose if a patient needs to start both MRI study and CT study, can we give MRI contrast and CT contrast on the same day itself?
Yeah, it can be given, but before giving, we have to check the patient. What is the patient renal efficiency should be checked before giving it. We have done the CT and MR studies in the same day, and we didn't find out any adverse effect. Even this question is, I think it's the recommendation is we can do the both MR CT contrast in the same day, but only thing is the patient renal safety should be checked.
Okay, fine. Thank you, Sheeba. Anyway, you have done a good job for our community because you extensively covered the area well, and it was a nice talk for both students as well as technologists. So anyway, thank you, Sheeba, very much. Thank you very much for your excellent presentation. And actually, it crossed the 1 hour, so I thought it'd be finished by 40 minutes or 45 minutes, but still, actually, it's okay. But we got the students and technologists got some information from that, so we are thankful for you for giving such an excellent presentation. Thank you, Sheeba. So that's all from ISRT Rayos 125 36 days presentation about MR safety. And we will back with live sessions in the coming days. Thank you very much for the listening, and thank you from ISRT.